Please welcome back today's host, Andrew Ross Sorkin, along with Chairman and CEO of Kaiser Permanente, Bernard J. Tyson, and Secretary of Health and Human Services, Sylvia Mathews Burwell.
Thank you, and thank you, everybody. We are going deep, as you can see, on healthcare today. It is, of course, the issue du jour post-election, the future of Obamacare, and I couldn't be more pleased to have both of these folks to talk about it and try to help us make sense of what is about to happen next. It has been your job to oversee what is affectionately, or not so affectionately, depending on what side of the aisle you're on, known as Obamacare, and it appears that it is now going to be repealed, or some form of that. What do you think is about to happen?
Well, the one thing that is happening that I think is important, because the law is the statute and the law of the land, is right now open enrollment is occurring. And that's the time period where those who are enrolled in the marketplace re-enroll, and those who are uninsured should come in and do it. And yesterday, the day after the election, we had the highest number of plan selections that we've had in this open enrollment since November 1st. And so that is part of what is happening, is everything is continuing. With regard to the specific question of repeal, I think right now is the time to move beyond the rhetoric and get to reality and the facts. And the facts that most people tend to know are that 20 million fewer Americans are uninsured. And so the question of, do you just want those people to lose their financial and health security? That's question one. I think the other questions that people don't understand in terms of the reality, because most people don't associate it with the Affordable Care Act. So for everyone in this room, I can guess that there would be very few of you that don't know somebody who has asthma, diabetes, has had cancer, some pre-existing condition. And in the world we live in today, you can't be locked out of healthcare. With a repeal of the Affordable Care Act, you could. For anybody, there may be parents here, you actually may have somebody who's 25 in this audience. Are you on your parents' plan? That's the Affordable Care Act. You can stay on your plan until 26. For anybody who has or uses preventative care, did anybody get a flu shot? Anybody here use contraception? Any of those issues, you no longer do co-pays or additional costs. And those are all the things. And because of all that, when the conversation comes to the point of the reality, I think it's going to be a very different conversation.
Okay, so let's talk about that conversation. Bernard, I want to bring you into this, but just give me one more second on this.
Sure.
If Donald Trump were to call you and say, hey.
I'll just read a book while you...
No, if Donald Trump were to call you and say, come talk to me. I've already pledged to the public that I'm not keeping Obamacare, at least as it's currently defined. But I want to redefine it. I want to call it something else, and I need to change a lot of it. And I know that you are the architect of parts of this. What would you tell him?
I think that we've been clear, and the president's been clear. We think there are improvements that need to be made. Encouraging competition, which I think the issuers and everyone thinks is important. We think that some additional financial assistance would be helpful. We think that we need to do some things to help with drug costs. And these are all things that require statute, which is what that conversation would be about. The idea that at HHS we should be able to negotiate on high cost and specialty drugs. I spent some time at Walmart, and that's actually how you negotiate price, generally speaking. And so there are a number of things that I think are important and can improve, and I think that's a conversation that's an important one, and that's the conversation we should be having. Right. How do we increase access, affordability, and quality in the United States health system?
Okay, Bernard Tyson, also known as, oftentimes on every list, the most powerful man in healthcare. 48 hours after, what is your reaction to this election? I know you sent out a note to your employees, and I know you got a lot of notes back. What did they say?
Well, I think it's fair to say everyone was surprised about the outcome. Because every time you turn on the television, you heard a consistent message that Secretary Clinton was ahead. And so I think as the evening went on for everyone in the country, and you started to see the votes adding up the way they did, I think everyone was surprised, me included. I think we're all now thinking through what that means, especially given President-elect Trump's view on the Affordable Care Act and some of the other things that he talked about during the campaign. You know, I agree wholeheartedly. I think that, and I'm hopeful that when his administration is in place and they start to look under the hood to really see what is going on, how this is working, the good, the bad, the ugly, work that still needs to get done. I'm hopeful that reasonable minds are going to figure out how do we continue to improve on the outcome, which is to make the front door of the American healthcare system available to everyone. And that's the way I view the Affordable Care Act.
And let me ask you this. You have been a proponent of the Affordable Care Act. What investments or changes in your business do you make in relation to it over the past, let's say, year or two as we plan for it to start to begin and then begin in earnest? And what investments would you make or not make if it gets repealed in earnest? Meaning, have you had to have a meeting with the board yet to figure out what we're going to do about all this?
But see, I run a unique organization. Kaiser Permanente is a unique organization. The members in the communities in which Kaiser Permanente exists, who happens to get their coverage through the Affordable Care Act, if they lose their coverage tomorrow, I still have to figure out how am I going to be there for them when they need the care. So it does not in any way eliminate my passion for making sure that everyone in these communities are getting appropriate care when they need it. The concern I have is, number one, I'm already starting to get the calls where people are fearful about what's going to happen. And so the questions are now coming. Should I renew? What does this mean? Am I going to get kicked out of Kaiser Permanente after January 20th? So I'm concerned about the fear factor that is going on. But I'm also hopeful that when President Trump is in office, you know, he said he was going to repeal the Affordable Care Act, but he also said he didn't believe in people suffering unnecessarily if they didn't have money to pay for care. So in that space, we still need to solve to how are we going to provide coverage and care for the American people. And I'm all in figuring out and working with anyone, as we've always done, to achieve that objective.
Secretary, I want to ask you about a comment that Bob Kocher had made in an op-ed in the Wall Street Journal. This is about, he was the Special Assistant to the President for Healthcare and Economic Policy 2009 to 10. He wrote a op-ed entitled, "How I Was Wrong About Obamacare." He said, over the past 5 years, published research, some of it well summarized on a Harvard Medical School site, indicated that savings and quality improvements are generated much more by independent primary care doctors than by your model, large hospital-centric health systems. I want to get both of your views on that.
The concept of delivery system reform, or changing the way that we deliver healthcare in our nation to promote affordability and quality, is something that I believe occurs in systems. And I'm sure you can talk about the examples of prevention that we see happening in systems like Bernard's own system, but also happens with providers. I believe that part of this is there are three things that we need to fundamentally do. And these three things are things that both providers and systems, hospital systems, and often insurers, because they interact with both of those, can participate in. The fundamentals of moving the nation to a place where we have greater quality and affordability, first, is we have to change the way we pay. And instead of paying for quantity, pay for quality. We have a fee for service. So every time there's a test, that's the incentive for providers and doctors. Instead of saying, we want to pay for an outcome. And the best example of that, one of the examples, is bundling, which means think about your mom going in for her hip surgery and her hip replacement. And right now in the world, in much of the world, every piece of that, from the person who tells her to put her dishes down, to the rug, to the anesthesiologist, to the surgeon, to the physical therapist, all paid separately. But when you bundle that and you pay for an outcome, you start to create different incentives. Second, we need to change the way we deliver in terms of integrated and coordinated care and do more preventative care. And the third thing is using data and information. Those are all things that both providers and systems can do.
Right. Talk about your system, though, and
Well,
that critique.
Well, it's a mistake to call me a hospital-based system, first of all. So that's the fundamental issue.
I'll take that on my own.
No, and I'm saying it for a point, because we've built this industry with the hospital being at the center, and then we've done everything else around it. At Kaiser Permanente, we're proving that care could be delivered everywhere. And so to your point about primary care, last year, our primary care encounters between our physicians and our members was over 100 million. 52% of those last year were virtual. So it's technology. So the whole point is care can be delivered in multiple ways. Right. The Affordable Care Act is intended to reform both insurance and delivery. And in my model, evidenced by what we're doing today, I think we are a proof point that you can deliver high quality care and make it affordable. And that's what we're working on. And it's building an efficient system to maximize delivery of care for prevention and then intervention when necessary.
What do you make of consolidation in the business? We had Mark Bertolini here earlier, Aetna trying to merge with Humana. A lot of the business executives, especially in the insurance part of this world, but also in the hospital world, have said that for all of this to work, to really bend the cost curve, we're going to need to do a lot of mergers. We're going to have to consolidate. We got to take extra supply out of the system. And yet we are in an instance, at least with Aetna and some of the other insurers, where the government said, no, we can't do that. So they would tell you that they're hearing two different messages at the same time.
So in terms of any specific merger, won't speak to that, and I think the Justice Department handles that in terms of the government. But the broader concept, I think what's important to measuring things and when and how things should occur is it's about the three fundamental things: affordability, quality, and access. And a lot of this actually is centered around the question of affordability. And when one thinks about affordability, there are several different things that can contribute to that. Sometimes scale can contribute to affordability, but also competition is something else that can contribute to affordability. And so I think it is, that is where one needs to apply the cost-benefit analysis in terms of what, over both the short and long term, results in the greatest affordability.
Do you think, where do you land on consolidation? You've obviously,
Well, I mean, we now have 11 million, almost 11 million people we take care of. We have almost 200,000 employees, 20,000 physicians, and we're a big organization. There's no question that scaling like that allows us to be competitive, efficient. We learn faster, if you will, because we have innovation going across the program. And there are benefits to doing that. But also being in a competitive environment allows us to wake up every day thinking very differently, which is, okay, that's good that we're doing this well, but now what's the next hill that we want to take? And so I think both of those needs to come together. I'm more concerned that if you look at the industry that is still, by and large, a fee-for-service, volume-based system, the incentives are still misaligned with what we're trying to achieve. My system is a capitated system, and there are other value-based payment systems that we can create. But the whole point is to align the continuum of care and make sure that the incentives are all aligned. And so in my case, the physicians, as I describe it, they control the dollars. And they're not incented or disincented to put a patient in a hospital versus a nursing home or medical office building. They look at how they should be providing care in the different care sites that we provide in our communities, mainly through the Kaiser Permanente system. So we need to have a way to coordinate the whole healthcare system. It doesn't have to necessarily be just like Kaiser Permanente, but the coordination is vitally important to create the continuity of care that's needed.
Let me ask you a separate question about drug companies and drug prices. The stocks of many pharmaceutical companies shot up in the past day and a half. There was a worry, as you know, that if Hillary Clinton was the president, there might be price controls. You saw that conversation take place. What is the right answer to drug prices?
I think there are a series of steps that are important, and I think it is about moving to the type of approach which was just described, which is an approach where we actually, it's not fee-for-service even in the drug space, that it's based on value. And so trying
even within the drug space.
Even within the drug space, I think paying for value is an important place, and that's a place where we, again, don't have the incentives aligned. And there is a proposal called the Part B premium proposal. And right now, the way that works is there's a base price and then a percentage bump.
Right.
And when you do it in that way, you are encouraging a prescriber to prescribe that which is most expensive because he will be paid the base plus a percentage bump. And so when that percentage is 6%, it's better for what your incoming payment's going to be to do it higher. And so there are things like that that need to change in the system. As I said, I don't think that negotiating equals price control. And I think that's one of the things in the conversation that people need to have, the real conversation. The negotiation, and we have suggested that you negotiate not on all drugs, but on specialty and high cost, and believe that you can get some of the results you need to do that. So I think there are a series of steps and things that one can do to push towards a more value-based approach to payment.
I know there's probably a million questions in the audience because this is one of those days, and given who both of you are, so I want to open it up early. But before we do it, and maybe the microphone folks can come down, and I don't know if you're even allowed to comment on it. Bill Ackman's going to be here in just a little bit, has a big stake in Valiant. And I was curious, given the pricing issues related to that company, you've watched the situation? You know what I'm talking about? A little bit?
In terms of speaking to specifics.
You're not allowed to. I tried. Okay, let's get some questions because this is one of those great opportunities 48 hours after the election. I can't believe I have 100 questions. No questions. I can't believe that. Oh, right here.
Hi, I'm Avi. I'm from University of Michigan. I'm working on a startup right now in healthcare IT sector, focusing on the value-based reimbursement for pharma drugs. One of the challenges that we have, so like after electronic medical records implementation, there's a lot of value in analyzing the data and building prescriptive diagnostic treatment solutions, and Kaiser is already doing that. What is government doing to bring together all this data that is being captured in electronic medical records so that innovators can access that and build tools that can improve quality and affordability of healthcare?
So I think with the electronic health records, the most important next step to getting value is to get interoperability. That at that point, and right now the health records exist, for 90% the electronic health records exist, but we aren't getting the value that we should because there's not interoperability. So in other words, your records at one physician are not easily accessible by that physician, by another physician or a specialist. So getting that interoperability is step one in terms of value, and that's both for providers. So if we're both caregivers and you're the primary caregiver and I'm the specialist, our ability to move that information back and forth speeds up. It reduces the number of tests. It allows me to understand things about the patient I should, and vice versa. And so that interoperability for the provider is important. It's also important for the user. So the consumer needs to be able to access those records to become a more engaged consumer and be a part of it. So that's step one on the EHR side. On the other side, in terms of using large amounts of data to reduce cost and improve quality in the system, I would suggest that I think one of the most important steps, sort of moving EHR, the electronic health records, to be a part, but the Precision Medicine Initiative. And so this is an initiative where the government will be launching a 1 million-person cohort to share the data and information. So the data will be in a space and will be de-identified so that researchers can use it. Because one of the most expensive costs, and this brings us back to drugs, is trials for drugs and how much money it costs to stand up a trial to test a drug. But when you have a cohort of people, and you can see the information. It will speed up the process. So those are two primary places of focus of using data and information to put downward pressure on cost and upward pressure on quality.
Yeah. No, I thought she answered it very well. And obviously, as you know, my organization, as you mentioned, we have all that data integrated. And the benefit, of course, in our organization is longitudinal data. And most of the pharmaceutical companies, for example, like to come in and do clinical trials with our members because we have the comprehensive electronic health record.
Bernard, given your model, how easy or hard is it to get a Rockstar physician?
That's what we have.
But there are special. The reason I know you have many, but my question is, there are these so-called Rockstar specialists who don't want to accept insurance, who don't want to be part of a big system, who want to operate on their own. How do you think about them?
Those probably will not work in my model, and they're few and far between. The benefit of Kaiser Permanente is physicians come to practice medicine, and that's what they get to do. So they don't fill out forms. They're not there to get authorization from people like me. They use their judgment. They work in a community environment of like-minded physicians. They compare and compete in terms of how can we get better. We invest in the practice. We invest in innovation. We invest in the technology. Right. And so we create an environment in which they are striving to perfect their craft, which is medicine.
Can this, by the way, and I know we got a question up there, but can this model work everywhere, or is it this? Do you think that it works best in cities?
Well, you know, many of my competitors who come in to view and look at our model, the mystery to them is how much we spend in terms of capital in our markets, because we go deep in every market that we're in, as you know. But the elements of how we build the integrated model, that's not unique property that's only for Kaiser Permanente. And there are models around the country that's looking at how to integrate without building all the infrastructure that we have, for example, at Kaiser Permanente.
Mike's got a question. Old friend from CNBC.
Thanks, Andrew. Good afternoon, and a great day. My question's for Bernard, and as a preamble, I'm a Los Angeles native, and I'm a Kaiser baby. We did hear Mark Bertolini earlier today say that it's all about bringing healthcare to the home, and that if people go to the hospital, as he put it, we failed. We just heard you say that more than half of your touch points were virtual. So what does the future of telehealth look like to you?
Yeah, you tell Mark he took my belief and he's out talking about it now. I'm kidding. Mark is a dear friend. I believe that as well, that we built this industry on a couple of fundamental things. First, it's a fix-me system. So when people started to live longer, they got sick, and we built a system to fix them. Secondly, we built it around our convenience. So we built pretty much the industry around a hospital-based approach, and then we put all the resources around that. That really was based on our convenience, how we wanted to do healthcare. And then we had a lot of people coming in to us for everything. I think what we're demonstrating is that a lot of care is not necessary for you to come on site to get that care. I think in the future, we're working on this right now in Oakland, California, in my innovation center, is we're probably going to end up in the 21st century with the home operating as a medical center, in which technology is going to allow us to monitor you remotely in your own bed. We're going to be able to bring the resources to your site. I think the possibilities are great for the future of how we look at care being provided out, as opposed to everything coming in to the four walls of a given healthcare organization. I'm very encouraged, especially as everyone is looking at us right now, that 52% of over 100 million encounters done virtually is not a pet project. That's telling us something. And by the way, the satisfaction level is extremely high. The quality measured through objectives, outcomes extremely high, and we're on to something because our members, number one, love it, and it creates a different kind of convenience. I would also say that I see in the not too distant future, and we're working with a couple of organizations now, where these wearables are going to become much more of medical devices. And they're going to be devices that augment the human devices, that gives us signals when things are going wrong with our bodies, that this is going to help in facilitating that process where people can get care earlier and upstream in more the prevention mode as opposed to waiting until something really happens and then you're in the episodic mode.
We have to leave the conversation there. You're wearing a Jawbone, I think, just so everybody
Yes.
knows, a little promotion. We had the CEO of Jawbone here a couple years ago. Thank you for this conversation. Thank you for your service to the country, and we appreciate it. Thank you.
Thank you.
Go to your client.